my pleasure to present to the audience the result of the LixiPark trial. So myself, I am Olivier Rascol. I'm a professor of clinical pharmacology and in charge of the Parkinson Expert Center in Toulouse. And I ran that study with Professor Vassilios Meissner, who is in Bordeaux. And the both of us, we have been working hard to make this possible. So you can see my conflict of interest. There are many, which mean that none of them are really crucial for me. And I just wanted to start the presentation by emphasizing that we have been looking for a treatment that could slow down the progression of Parkinson's disease for many decades. I mean, actually, the first large study was called DataTop. It was run by the Parkinson Study Group in the US, and the conclusions were uncertain. It was impossible to conclude if the difference between the two groups were related to a symptomatic benefit, which is more like what we know is levodopa, or to any underlying benefit on neuron survival. But anyhow, this was not the only trial, and there have been dozens of that studies, and they all failed or were inconclusive. And the question was, we had a lot of debates among the scientific community. Are we targeting to the proper mechanism? Because there have been a lot of hypotheses, and could be that we were not targeting to the good one. We were also questioning the quality of the design of the studies, and we have been working a lot to improve that. We were trying to find the best way to measure an effect, which we called outcomes in our jargon. And we also wondered if there should be a specific population where it would be easier at the beginning to show an effect. So with all this in hand for 3 decades, and in spite of the failures, we have been continuing working. And now in 2024, there have been a lot of changes in the picture of our understanding of Parkinson's disease. And there are many new targets to try to work on to show that finally we can slow down the progressive worsening of Parkinson's disease over time. So I'm not going to enter into detail about these many complex mechanisms, which are still not fully understood. But I just put it on the right in here, some of the most recent targets, which actually at the moment are supporting ongoing clinical trials. But I'm going to focus on one, which is related to what we call insulin resistance and has something to do between diabetes mellitus and Parkinson's disease, even if this is not obviously at the first look something that would have been considered. Now, among the treatment for Parkinson's disease and among the mechanisms which are related to Parkinson's disease, there is a special type of receptors that we are calling GLP-1 receptors. And these are playing the role into the effect of insulin, because when you stimulate these receptors, you can potentiate the release of insulin, which is an hormone which is reducing the level of glucose, and also suppressing the secretion of glucagon, which is another hormone which is increasing glucose plasma levels in response to ingestion of nutrients. And there has been major progresses in the field of diabetes mellitus with these compounds and the discovery of these receptors. And these receptors, of course, when people are looking at diabetes, they are mostly targeting at those receptors which are in the pancreas. But we also know that there are such receptors within the brain. And these compounds can improve diabetes mellitus, not only because they modify the response to insulin, but also because they are targeting at the satiety centers in the brain. And this is why patients on such medication are losing weight. And when we were thinking about looking at these hypotheses in Parkinson's disease, the advantage was that there was a lot of work which has been performed before in the field of diabetes mellitus, a number of drugs which are listed in here, which have been developed and can be used in humans. So we didn't have to start from scratch with the new molecules, but rather to consider to repurpose existing molecules marketed for the treatment of diabetes mellitus, but with the target of looking at the effect in patients with Parkinson's disease. There are several ones. The Cure Parkinson's and colleagues in the UK have been working actively on exenatide, but the drug we are going to talk about today is called Lixisenatide, which is relatively close to exenatide. And these drugs usually are used using pen jet, and the patient self-inject subcutaneously these drugs for diabetes mellitus, and this is the way we have used these drugs for Parkinson's. Now, just these pictures to let you know that Lixisenatide is in here at the bottom of the list. That there have been different of these GLP-1 agonists that are or have been tested in clinical trials in people with Parkinson's disease, just to check if the hypothesis of using this drug would or not improve the course of the disease over time. Exenatide, liraglutide, semaglutide, lixisenatide, and a few others. So why should we use these medication in patients, in people with Parkinson's disease? Well, there is a rationale. The first thing is that when you look at database of patients with diabetes mellitus, and when you try to identify the risk of these people with diabetes of having Parkinson's disease, the risk is increased. So there is something linking both diabetes and Parkinson's disease with an increased risk of developing Parkinson's disease among the people with diabetes mellitus. And also, interestingly, not all patients with diabetes mellitus are treated with GLP-1 agonists, but the subgroup of people with diabetes mellitus on GLP-1 agonists, well, epidemiologically, the risk of developing Parkinson's disease is reduced. The second rationale for that is that when some scientists have been looking at the brain of people with Parkinson's disease who donated their body to science, they have been exploring area in the brain what we know are involved in the mechanism of Parkinson's disease, especially the dopamine neurons in the substantia nigra. And when these scientists have been looking in the brain of people with Parkinson's disease versus brain of people without Parkinson's disease, they were able to show that there were some biomarkers which suggested that there is some impairment in the insulin signaling at the level of the neurons. So there are common mechanisms in the neurons linking this insulin resistance and insulin signaling in the neurons and Parkinson's disease. And finally, there have been colleagues who have been using animal models, and they have been developing some models where you can overexpress alpha-synuclein so that the mouse are developing something which resemble Parkinson's disease in a rodent. And when they tested these animals and they treated them with GLP-1 agonists, again, there were conversion observation that with such medications, the lesions in the models and the behavior of the mouse were less severely affected than in the group of the same animals who received a vehicle. So a lot of work has been done to try to understand how these GLP-1 agonists could in fact have a positive effect on the neurons in the brain of people with Parkinson's disease. And this is illustrated on the right of the screen. And of course, it's super complicated. I'm not going to enter into all these molecular details. First, I'm not a molecular specialist. And second, it's still not completely understood. But there is a list of the different mechanisms that could explain why using such medication in people with Parkinson's disease, there would be an improvement in the survival of the neurons. And that may be related to mechanisms related to inflammation, for example, but also to pathways which are enhancing the survival of the neurons or other of these mechanisms. So with this in hand, our colleagues from UCL in London have been the first who have been testing the hypothesis in people with Parkinson's disease and with the support of the Cure Parkinson. And this is the first pilot study. It's a small study. Methodologically, you could claim that there was no placebo, but there was a control arm. But to make it simple, within 12 months and following up 40 people with Parkinson's disease, they've been looking over time of the score of a clinical scale that we are calling Movement Disorder Society Unified Parkinson's Disease Rating Scale, MDS-UPDRS, and looking at the subscore of this scale, which is scoring the severity of the motor symptoms. And they've been looking at the score over different visits for 12 months. And you can see on that figure that the patients, the group of people with Parkinson's disease represented with a dotted line, they have a score which remains below the score of the group of patients who have not been receiving the treatments. And this is the first illustration that maybe there is something different and some efficacy of exenatide in this case, which is this GLP-1 agonist. And our colleagues from London, again with the support of the Cure Parkinson, have been publishing in the Lancet in 2017 a confirmatory pilot study. Again, it's not a very large study. It's one center in London, but it's double blind, which means that the patients were, or the people with Parkinson's disease were randomized either to placebo or to exenatide, but nobody, the patients or the investigator, were aware of the randomization. And again, when we look at the score of these MDS-UPDRS motor score over time, well, in blue, you have the exenatide score. In red, you have the placebo score. And again, you can see, as in the previous study, that there is a difference between the two groups, and that in here, the patients on exenatide had a smaller change over 12 months in the severity of their motor score versus baseline, which again is an indication that the drug may work, if I can say it this way. Now, this is where we come to this LixiPark trial, which was run by a lot of my colleagues in France via a network that I am chairing, which is bringing together 27 expert centers for Parkinson's disease in France, and who have been trained to work together and run different research projects over the last 15 years. And that's the result of that study have been very recently published about a couple of weeks ago in the New England Journal of Medicine, which is the kind of the most famous medical journal worldwide. So just to illustrate how complicated it is to organize and implement such a study, we had to work for about 10 years. I went back to my mails between the Cure Parkinson and Sanofi to initiate the project, and that was 2014. Now we are 2024, so it's 10 years of effort. What we were looking for at this time was that we wanted to set up the study, so we needed to have access to the drug and we need to have funding. And this is where Cure Parkinson was really very helpful, because it co-funded with the French Ministry of Health the cost of the study, and Sanofi, which is a French pharmaceutical company, which at this time was marketing Lixisenatide, was nice enough to accept to give the treatment for free and also the placebo. And then we had to get a sponsor. Vassilos Meissner and myself have been, working hard, and the network with the 21 of the 27 centers and the coordination have been working all these machinery for a large clinical trial. Now, sorry, it looks like mine. Okay, so the study design, how did we really work? So I already said that 21 centers. It was 158 people with Parkinson's disease who agreed to participate. And we included them over 2 years, and we followed them for 14 months. You here have on the map of France the different centers involved in that study. And basically what we've been doing, this is the very simplistic way to represent what we call the study design. So we screened patients, we checked that they were eligible, then they were randomized to receive placebo in blue, where they got subcutaneous injection of placebo every evening, or patients who were randomized to receive the active treatment, Lixisenatide, again, once daily with subcutaneous injection every evening. The dose that we chosen was that from what we knew from diabetes mellitus, 20 micrograms per day. And there was, for the first 2 weeks, there were a first step of dose with 10 micrograms and then 20 micrograms. And we knew that in some patients with diabetes mellitus, patients have some gastrointestinal discomfort with this dose. So they were allowed, if they had nausea or vomiting, to go back to the 10 microgram per day dose. And we have been following the patients and the cohort for 12 months, where everybody was assessed at every visit for the severity of their motor symptom while they were receiving their current anti-Parkinsonian symptomatic medication, levodopa or others. But we also followed up the cohort for 2 more months after everybody had stopped placebo or Lixisenatide, and they were evaluated at month 14, which means that at this stage, they have been out of treatment, Lixisenatide or placebo, for 2 months, and we also assessed them after an overnight washout of levodopa and other symptomatic medication to try to have a picture of their symptoms without the effect of their current medication. And this part is important because if there is an effect which is observed at month 12, and if the effect persists for another 2 months, it is supporting the concept that the drug is probably having a neuroprotective effect rather than an effect which is similar to what levodopa is offering to the people with Parkinson's disease. Because if you stop levodopa for 2 months, then the benefit on the symptom is completely cleared off. Now, we have been testing a lot of outcomes, what we call in our jargon, but the primary outcome was to assess what was the change from baseline when patients entered into the trial and to 12 months, 1 year of follow-up on that motor score of the MDS UPDRS. And there have been, but this is assessed by the investigator, by the doctor or the healthcare professional who is assessing the symptom at each visit. So it's reflecting the perception of the symptoms by the doctor and not just by the people with Parkinson's disease. And this is captured by other part of the score, which are the subscore for motor activities of daily living. We collected this information, but we knew from the beginning that in this population, I'm coming back to that later, who were people at the very early stage of Parkinson's disease, it is very difficult to pick up an effect within such a short follow-up, which is 1 year. Now, anyhow, we had to choose and to make a selection of the people who were entering into the study, and the choice was to focus on people with Parkinson's disease early enough in the disease so that their motor condition would remain stable without what we call the motor fluctuation in response to levodopa, which can occur quite commonly after a longer follow-up of the people with Parkinson's disease, because the response to levodopa begins to be less stable and fluctuates from one time to the other during the day, depending on the timing of drug intake. So we focused on people with a diagnosis which was recent, less than 3 years, with a treatment which was stable and optimized with levodopa or dopamine agonist or MAO-B inhibitor, and that these people were receiving it for less than a year, and we had the hope that they would remain with the same dose of these symptomatic treatments all along the 12 months of follow-up. And this is another way to scale and grade the severity of Parkinson's disease. And when people with Parkinson's disease have a Horner stage less than 3, this means that their motor disability is only mild. So we have been pre-selecting 177 people with Parkinson's disease. And again, the centers in France did a good job because most of them were eligible. We had what we call a very low rate of screen failure, which means that people finally who were not fulfilling the inclusion-exclusion criteria to be allowed to participate. And we finally randomized 156 people, and they were randomized 78 to Lixisenatide and 78 to placebo. And another compliment to the people who participated in the study, regardless they were people with Parkinson's disease or they were the staff of the centers, we had a very low dropout rate, which means that 95% of the people who entered at baseline within the study, they completed the study as planned over the 12 months. And usually many things can happen over a year, and the dropout rate in clinical trials usually is rarely as good as that. Now, just to illustrate that the people who participated in the study were in line of what we had in mind. So you can see that they were about 60 years of age. So they had been diagnosed for Parkinson's disease for 1.4 years, so recently. When you look at the score of our primary outcome, which is part 3 of this MDS-UPDRS score, it is 15. The maximum, when the score is 0, that means that there are no symptoms. When the score is maximum, the worst possible case you can think of, it is 132. So you can see that at baseline, the symptoms were moderate, but I remind you that they were on medication, so probably levodopa, dopamine agonists, and MAO-B inhibitors were doing a good job and were masking part of the symptoms. They were receiving a relatively low dose of levodopa equivalent, 300 milligrams per day, which is not much. It's the equivalent of 3 Cinemat 100 per day. All of them were on levodopa, but a substantial number of them were receiving in complements MAO-B inhibitors like selegiline or azagiline, or dopamine agonists like ropinirole or camipesole. So these are the results, the exciting part of the study. So we are focusing on the change between baseline and month 12 in this course, which is assessing the severity of the motor symptoms by the investigator. And of course, we know that the current medication, they are very nicely efficient on the symptoms, but they do not have an impact, as far as we know, on the fact that the neurons keeps getting sick, and so that the disease over time is worsening, and that the symptoms and the severity of the symptoms are increasing. And this is illustrated on the left, because we are starting from 15, as I told you, at baseline in both groups, but those on placebo, they have a trend for having higher score up to 18 points after 12 months of follow-up, which illustrate that there has been some progression of the disease in spite of the treatment, while the patient Lixisenatide, well, more or less, the severity score of the motor symptoms did not change from 12 months to baseline. And this is illustrated in here. So you have the change from baseline scores at 6 months and at 12 months. And it's easy to see that at 6 months, there is already a trend with some increase in the score on patients, in people with Parkinson's disease on placebo. But this is not statistically significant. There is no statistically significant difference. But after 12 months, the difference, there is a worsening of 3 points in the group of subjects on placebo, and there is nearly no change in those randomized to Lixisenatide. We looked if there was an effect of age. There are many other potential factors to check if some type of people with Parkinson's disease might be better responders than others. But from a previous finding in other studies, there is the possibility that younger patients might get a better response. And in fact, we must be very cautious because that was not pre-planned in the analysis. But still, it's interesting to observe that when you look at the group of subjects below age 60, as opposed to those over the age of 60, the difference between the two arms is larger in the younger subset of the population, which may also be consistent by the fact that younger patients might be responding better. And don't ask me yet for what reason. I think this is what we are going to work on. There are some hypotheses, but it's just at the moment an observation. Now, we have not been looking only, like in other trials, to the primary outcome, but we looked also at other secondary outcomes. They are listed in here, which is a publication in the New England of Medicine, which is very hard to read and understand, especially for people who are not familiar with these methods. So I put it on the right, the take-home messages. The first interesting observation is referring to the observation of the score of the people in the two arms at month 14. I remind you that we followed up the patient for 12 months on treatment, and then we stopped, and we wanted to see if after 2 months having stopped Lixisenatide or placebo, the difference between the group was persisting or not, because if the difference was disappearing, that would have been in favor of a short-term symptomatic benefit on the model of what we already know with a drug like levodopa. But on the opposite, if the difference persists after having stopped the treatment for 2 months, this is supportive of the concept that the drug has been working in a different way, which means by being neuroprotective, or to make it short, improving the survival of the neurons or improving the capacity of the brain to compensate. And actually, after these 2 extra months of follow-up without Lixisenatide, the difference between the two groups persisted, which is in favor, in our view, of the fact that this illustrates a neuroprotective benefit rather than a symptomatic effect. The other observation, which is important for understanding the results, is that, as expected, in this population of people with Parkinson's disease in the early stage of the disease, they did not require to change much the dose of levodopa between baseline and month 12. And this is very important because if in one group the dose of levodopa had increased more than in the other one, that could have influenced the primary outcome and could have made our results difficult to understand. But just to understanding here, the change in the dose of levodopa between the two groups was really marginal, 4 milligrams per day, which means nothing. So again, it reinforces the fact that what we have observed in this cohort is really something which is not biased by the fact that some people might have received more levodopa than others. And the last comment I wanted to make on these secondary outcomes is that we were disappointed, but we were expecting that none of the patient's outcomes measured by the patient's perception of their symptoms allowed to detect a difference between the groups. But again, we followed the patient for only 1 year. the patient had very mild symptoms because they were at the early stage of the disease and they were receiving efficacious treatment. So we know that if we want to use such outcomes, we have to enroll many more people or to follow up these people for more than a year to expect to be able to capture a difference. And in fact, this is what may look in subsequent studies like a phase 3 type study. Now, of course, when you expose anybody to a drug which is efficacious, you can expect that the drug might also have induce adverse reaction, and this is what we have been looking at. And again, this is a table from the publication. There are a lot of numbers. They are small and not easy to read, but I'm going to summarize the difference between the two groups. So first, as expected, there were more people on Lixisenatide as opposed to placebo who got some gastrointestinal discomfort, nausea or vomiting. About half, 45 patients on Lixisenatide and only 10% on placebo get some nausea or vomiting. But what is important is that these symptoms were mild or moderate, and none of them forced the participants to stop the study. In some of them, we had to reduce the dose from 20 micrograms per day to 10 micrograms per day, about 35% of those randomized to Lixisenatide, only 4% on placebo. But anyhow, the severity of this adverse reaction was mild and moderate and did not induce premature discontinuation. The second comment is that with this class of drug, and in patients with diabetes mellitus, it may be good, but people lose weight because there are, I told you that there are some effects in the brain in the society center. But in this cohort, in the LixiPark study, well, the weight loss was very marginal. 6 patients on Lixisenatide reported that they lost some weight, but in here, we have looked at the mean weight at baseline, month 6 and month 12, on placebo and on Lixisenatide. And it's easy to see that there is no significant change between the two groups, which means that with Lixisenatide at this dosage over a year in people with Parkinson's disease, weight loss was not an issue. Now, another interesting thing, and I don't know what we can do about that, but when you look at other relatively common adverse reactions reported by the participants, well, those who were in line with pain, and pain is a symptom of some patients with Parkinson's disease, well, pain reported in the limbs, in the back, or sciatica, was less common on Lixisenatide than on placebo. And again, it's just an observation. I think we should not really drive comments too much at this stage, but it's something that I hope we will be working in the future upon. Now I'm going to finish this presentation with some questions. So we strongly believe that this is a multicentric study. It is double-blind, and we observe a difference which persisted after 2 months of washout at the end of the study. So we believe that this is a signal, and this is consistent with what was reported on exenatide by our colleagues in London, that there is something which shows for the first time that in people with Parkinson's disease, this medication can slow down this progression. But as I told you, the difference between the two groups was only 3 points. So that's not a big difference. It is statistically significant, but it's not huge. Of course, the score at baseline was 15. So 3 units, 3 points is about 20%. So there are publications in the scientific literature trying to understand if 3 points is meaningful for Parkinson's disease. I'm saying in a clinical perspective or not. Well, it's a difficult area. I think we should work much better on that. But this publication, which is frequently quoted, is considering, and the result of that is that 3.25 points is supposed to be the minimal difference in the MDS-UPDRS, which is correlated with the fact that the people with Parkinson's disease can perceive a difference. So in the LixiPark study, it's 3.8 units, so it's close to this 3.25, but it's not exactly it. So one could question that it might be not yet sufficient. Well, I want to emphasize, that this 3.25 unit was calculated in a population, not exactly the same one as LixiPark, because these were patients, subject with a more advanced disease, longer disease duration, higher dose of levodopa. And second, we must remember that we have been following the subject only for a year, and that most of the difference was driven by the change in the placebo arm. So one could speculate that if we would have been following up the patient for 18 months and not 12 months, maybe we would have a chance to reach these 3.25 points, and that's also something for the future. Another discussion that we are having is that, yes, in the LixiPark study, the worsening of the score over 12 months was these 3 points. And the question is, maybe you are aware of the fact that last year or a couple of years ago, there has been two other trials testing another target, not at all dealing with insulin signaling in the brain like we did, but looking at the accumulation or of alpha-synuclein, or the spread of alpha-synuclein from one cell to the other using monoclonal antibodies. I mean, these studies did not show a positive result, but what they showed is that in these studies, the worsening of the same score over 12 months was 5 points, which is larger than 3 points. And what we have to understand is that these patients were not exactly at the same stage than the people in the LixiPark study. They were non-treated, and they were at about 10 months from diagnosis, while I remind you that the LixiPark patients, they were at about 1.5 years from diagnosis. And we know that the progression of this change of the score over time is not exactly linear, and this may explain the difference. Now I'm going to finish by 2 slides which try to raise the point, are all GLP-1 agonists the same or not? In other words, is it a class effect, as we say in medicine, or are there differences between the different drugs of this family? And I showed you in one of the previous slides that there were different GLP-1 agonists which were available to treat diabetes mellitus, and that there have been, or there are, different studies which are ongoing with different drugs. And so I remind you that exenatide, even in small pilot trials, providing some positive results consistent with the LixiPark findings. But earlier this year, there has been another GLP-1 agonist, which is called NLY-01, which is very close to exenatide, but is a much bigger molecule. And in fact, it's interesting to increase the molecular weight of these drugs for diabetes mellitus, because it helps to change the way to administrate the drug to the patient. And for example, not to need to administrate the drug by subcutaneous injection every day, but only every week, which is more convenient to the subject. But this drug, which is a parent of exenatide, has been tested in a clinical trial in Parkinson's disease, and unfortunately, the study was negative. They did not observe the difference that the group of UCL observed with exenatide and the French network observed with Lixisenatide. You can see in here, this is the same score as we used, and these are different doses of and LY01 or placebo, and this is over months, over a year, the increase in the score reflecting the progression of the symptoms, and there is no difference between the groups, so the study is negative. And in fact, it looks like, what we are targeting at are these GLP-1 receptors located in the brain. And if you increase the molecular weight of these compounds, they may not cross the blood-brain barrier as well as smaller molecules. And of course, for diabetes mellitus, this might not be a big issue because the main target are the receptors in the pancreas. But if we want to protect the neurons in this cut, it looks like it's important that they have access to the receptors we are targeting within the brain. And if the blood-brain barrier is preventing the drugs to properly enter into the brain, this may explain why there has not been an effect observed in the previous trial. And there have been people working on this aspect. I'm not going to enter into the details, but this is when you administrate to mouse different GLP-1 agonists or related compounds. These are the concentration in here below within the blood. This is a schematic representation of the blood-brain barrier, and these are the concentration observed within the brain. And you can see that with Lixisenatide, there are detectable concentration of the compound within the blood-brain barrier in the brain, but with other compounds which probably have higher molecular weight, then there is no evidence of benefit. So that could be one explanation. So I'm concluding to say that, well, LixiPark is a nice study because it was simple and robust and showed a difference. And thanks again to the Cure Parkinson's and to the French government and to Sanofi and to the people with Parkinson's disease and to all the people who work on the trial to make it possible. The conclusion and the result, we find that there was a difference between the group in the worsening of the motor score over a year, and this is supporting a disease-modifying, or let's call more simplistically, a neuroprotective effect, and especially because we were able to observe a difference which was maintained after 2 months after the end of exposure of the cohorts to Lixisenatide. Well, the difference is not huge, it's 3 units, but this is reflecting also the fact it is not progressing fast, so we need to follow up people with Parkinson's disease probably longer to see a larger effect, but one could speculate in a skeptical approach that maybe this is all what the drug can offer, and it's true that if this is all what the drug can offer, 3 units is not spectacular and might question the clinical importance of that treatment. The tolerability, there were adverse reactions, but the tolerability was very similar from what is known from diabetes mellitus. The dose that we've been using, we had really no indication of what dose to use specifically for people with Parkinson's disease. So we used the dose which is recommended for diabetes mellitus. But it could be that a lower dose or a higher dose might be more efficacious or just as efficacious. Just to give you a partial information, I told you that about a third of the cohort of people on Lixisenatide had some nausea, and they were allowed to reduce the dose from 20 to 10 micrograms per day. And when we look, the number are small, so we must be cautious. But when we look at the response, it's not very significantly or dramatically different from the 20 micrograms. So it might be that 10 micrograms might be sufficient. And if so, that would be good because that would reduce the risk of, for example, gastrointestinal discomfort. Obviously, this is a pilot phase 2 study. You know that when developing a drug for a new indication, there are different steps, phase 1 to 3. So we need a phase 3 study to confirm this finding. And actually, our colleagues from London, again with the support of the Cure Parkinson, are currently running a larger and longer study with exenatide. So we are in the same situation, and we are anxiously expecting, as everybody, the result of this larger phase 3 study with exenatide. And we will have also, if we can have access to lixisenatide for this subsequent study, we will have to run that type of study to have more patients, to test if the age or other factors are important, to test if the same effect is still observed in people at a later stage of the disease, and also to test longer exposures and different doses. I'm going to conclude that, so this, in my view and in others' view, is bringing a lot of hopes because we have been facing 3 decades of negative results, and that was a bit depressing. So great that with exenatide and lixisenatide, which are both reinforcing mutually the reality of this effect. So it's good. And for the future, you must be aware that there are new generation of these kind of medication to treat diabetes mellitus. So, and they are acting in different way with dual action of twins receptors, which may enhance the response. So it could also be the case for the response in Parkinson's disease, but we will need to test that. And also we will need to better assess if these compounds, which are now on the market for diabetes mellitus, when we will be trying to test them for Parkinson's disease, well, do they cross the blood-brain barrier in a proper manner, or it is going to be an issue which may mitigate the findings in this new indication. So again, thank you very much. I'm happy to answer any questions.
Professor Rascol, thank you so much. That was a fantastic overview of what was a very important piece of work. I'm sure that there are questions from the floor. So are there any questions from here, or are there any questions online, Alex, as well? Okay, so thank you, Rosie. Let's hear from you first.
Hi, I've personally been on the exenatide recent trial, so I'm watching the results very avidly. But is there a reason why the lixisenatide trial might be a safer drug to go to the next phase than exenatide? And will you input the results from the exenatide trial to do the next trial more wisely?
Well, I think exenatide and are quite close compounds. I'm not aware of head-to-head comparison between diabetes mellitus. I must confess that one of the reasons why we chose lixisenatide for the study is very pragmatic. The drug was marketed and produced by Sanofi, which is a French drug company. And so we had some kind of, with the support, we had some, easier connection with our colleagues from the industry. And this is mostly why we have been choosing lixisenatide. I am not aware of any preclinical evidence that one or the other might be working better or might be better tolerated. I think that for other compounds, the question of the capacity to cross the blood-brain barrier is important. And this may explain why some of the other GLP-1 agonists, which are very good to treat diabetes, might not work as well for Parkinson's disease, but otherwise exenatide, lixisenatide. These are 2 relatively old drugs now. I told you we started 10 years ago to think about the study. So Sanofi is not marketing anymore, even for diabetes mellitus, lixisenatide. And so the question will be, is this drug going to be available for the next step for Parkinson's disease, or should we start from scratch with more compounds?
Olivier, thank you. Alex, can I give you the microphone for one online?
Mm-hmm. Yeah, a question from online. Is exenatide also more effective in younger Parkinson's patients? Because you've showed that lixisenatide has an age effect.
Well, there is an age factor on the NLY01 trial, which is negative, but we've been performing post-hoc analysis, and it looks like there might be an effect in these negative trials in subgroup of patients with younger age, and this is why we tested it in the LixiPark study. Referring to exenatide, I am not directly involved in the available data, but I think that Richard has been looking with others on this aspect, and if I am correct, if they can confirm, it looks like this is consistent across the study. So this is something that we should explore further.
Olivier, just to add to that, there was a post hoc study that Dylan Athauda undertook with the exenatide phase 2 data, and they did start to see a beginning of a trend, which is why I think we're keen to keep hypothesizing around this and understand, what is happening and why might you be seeing a slightly stronger effect. Are there more questions from the floor? Oh, Rosie, thank you.
So piggyback from that early patient population, is there more way of looking at early onset but fast progressors? I'm asking this based on the ALS study from Amilex, that if that's something possible to stratify. Thank you.
Yes, it is, and it's a very good point. And it's not only enabled, there's a very publication of the Pasadena study, which have been looking at different factors and help to have a greater chance to see an effect, so faster an option in ALS. We've not been looking at that, but it is a possibility. Of course, the price to pay for this approach is that then you exclude more patients, and then you have a more narrow indication.
Yeah.
It is hard to recruit. So for proof of concept study, it might be helpful, but I think that the more we want to progress to provide a treatment for the entire population, the more we should emphasize to be inclusive and try to, but on the other hand, it depends also on the mechanism of action.
Yes. Yeah.
So well, they are now in Parkinson's disease, drugs targeting activity of some enzymes, which are linked to some genetic variants. And of course, it's not entirely sure, but it's probable that in people carrying such variants, there is a greater chance to see a benefit, even if one cannot exclude that others who are not carrying the same variant might not still be responding, but maybe less. But yes, and it's not only fast progressors, it might be for medication, it might be other aspects. So we would have to explore that further.
Thank you very much. Another question online.
Another question online. Do GLP-1 receptor agonists have any other effects, such as inhibiting alpha-synuclein deposition?
Oh, yes. And I apologize, I'm an expert in this background, but it looks like there is some effect on alpha-synuclein oligomers, or whatever you call it, on mitochondrial function, on lysosomia. One of the effects, which seems quite important, is that this impairment of insulin signaling at the level of the neuron and in the brain is generating inflammation and activated microglia, which are immune cells within the brain, which participate and might be contributing to neuronal death. And it looks like these drugs, these GLP-1 agonists, may have an anti-inflammatory effect, which might help in facilitating the survival of the neurons in spite of electrical mechanisms related to